Welcome to another medical town hall. If you are just joining us, please put your name and your camp on your video so we can see who all is with us. And if you haven't, please turn on your video so we can see who's talking. So hopefully joining us tonight will be Dr. Rafi, is a pediatric infectious disease physician, but based on being on the West Coast, he's still potentially working. So
I see him.
Join us if he, is he on? Okay, great.
Yeah.
So welcome. We just wanted to start with our kind of usual, make sure that people understand that this is something we want to be interactive, throw out questions, throw out ideas. We are, not to put you on the spot, Dr. Rafi, but we would like to throw it to you first. Just see if there's anything you want to update us on or thoughts you have from the hospital and the infectious disease world.
Sure. Thank you. Thank you so much. I just did want to just clarify one thing, Dr. K. I'm actually adult infectious disease. I'm not pediatric infectious disease. So caveat. So you all know way more about pediatrics than I ever will. But I do specialize in
kids at heart, so it doesn't matter.
I'm definitely more kid than any patient I take care of. So thanks for the opportunity to give a brief update. I know many of you are medical providers yourself and are in the field and caring for people with COVID or suspected COVID also. So please, anyone with more local experience and experiencing kids, please chime in. It's what's clear is a lot of the computer models of the epidemic have been wrong, and I think a lot of us suspected that this was going to be the case because people who do a lot of modeling work always like to say all models are wrong, some models are useful, because you can basically make a model say whatever you want. It depends what you put into it. Many of us have been following the University of Washington, Seattle IHME model, which predicted that we would be at about 60,000 deaths not until August. And obviously, so that model was, unfortunately incorrect. And there are some very scary models coming out of England that things are gonna get even more dire. And the bottom line is, I think we don't know. I will tell you that I'm concerned that we don't have enough testing and public health following and quarantine and isolating of identified cases to be really ready for the kind of opening that I think we're going to be getting to see. And there's a model out of Mass General in Boston that suggests that if we in fact do start to reopen things without really good widespread near universal testing, contact tracing and isolation, we are going to be in a situation where we're seeing a second wave even as early as late summer. So I think the one thing that's becoming increasingly clear is this isn't going away. This is going to be affecting us and our camp planning for the foreseeable future, probably, if I'm gonna make an educated guess, until we have a good vaccine, and then the vaccine effectiveness and its uptake are gonna be really important in understanding what return to normalcy might look like. The one thing I did wanna bring up, because you all probably know way more about it than I do, is there have been some really scary reports of a pediatric inflammatory syndrome coming out of New York City that seems poorly described and poorly understood, but is really turning on its head our notion that this is a benign or almost irrelevant consideration for kids. And that, the worst thing I think some were considering before was that kids represented asymptomatic vectors. And I think it's really becoming clear now that that may not be the case at all. And it may be way more important to understand this spectrum of disease in detail before we make proclamations about what's going to happen with future camp seasons and activities than we originally thought. But one last thing, and then I'll stop talking because I do tend to ramble on a lot, as you've probably noticed, is there's been a lot of interest, of course, in therapeutics and when we're going to have good therapeutics. And it's been really maddening to providers who live and die by rigorous science to see what's being tossed around in the lay press and even by authorities about what we know and don't know about available therapeutics. And at least from where I'm sitting, the bottom line of what we know right now is there's only been one therapy that's even shown a signal of any activity, and that's remdesivir, which is this investigational product, which it sort of, at least in its first blush of what's been presented in a non-peer-reviewed context, seems to sort of be a Tamiflu for COVID. It shortens length of stay by a couple of days, but there was not a statistically significant difference in deaths or mortality. We're waiting for the detailed data to be presented and published in a peer-reviewed fashion to get a much better sense of in what populations it might be most effective. And importantly, it was not a completely safe drug. It did have some important liver side effects. So that's the only drug that in a randomized double-blind trial has been shown to have a statistically significant effect that at least where I'm sitting, I'm believing at this point. So I think until we have better therapeutics and likely a vaccine, we're going to be dealing with this for the foreseeable future. And I'll stop there. Thanks again for inviting me. I really appreciate it. Happy to answer any questions.
Thank you, Dr. Rafey. We appreciate you you taking the time to be here with us. Really do. So if anyone does have any questions for Dr. Rafey or anyone in the group, please feel free to share them now, or we're monitoring the chat as well. If you have any questions there, we'll make sure they get asked and answered.
So I'll throw out, does everyone on the call know what Dr. Rafey was talking about with the pediatric multi-system inflammatory syndrome that there's been some reports out on? People have heard about that and know. In case you haven't, it's as yet not completely characterized syndrome that's been occurring in pediatric patients, I think roughly 4 to 6 weeks after exposure or thought exposure to COVID, and has caused some pretty significant problems for several kids. I think the last I heard, 1 or 2 deaths from it. I'm a little bit behind on some of the data on that, I apologize, but certainly Kelly said they're seeing it in New Jersey. Certainly I think lends an interesting new twist to this when we had all been kind of trying to decide, well, we can't have camp because we don't want people to get exposed, but now it looks like even longer time their kids are going to be at risk. So it's something we definitely need to keep in mind.
There's a question in the chat that hopefully maybe Dr. Rafey can help us out with. In looking at models and with increase in testing, we'll see more cases. In order to identify downward trends, is it more accurate to look at hospitalizations and deaths versus strictly positive testing?
Yeah, I think it's a really good question. I think both measures are really important. Of course, as you scale up testing, you're going to find more cases. So that's really important from both an epidemiologic standpoint to understand the extent of active disease, but also for interventions to prevent spread, right? Because you want to identify people who have active disease and get them quarantined, get their family members tested, get them isolated. The hospitalization data has been fairly consistent, somewhere on the order of 20% of people, at least with diagnosed disease, seem to require hospitalization. And that's been true both in Europe, in the Asian experience, and here, depending on the location. And then mortality, it's so controversial right now. There's all this information swirling if people are inappropriately attributing some deaths to COVID, but people are dying with COVID, or if they're actually dying of the virus. So right now there's so much, there's so many different ways that things are being reported. that I don't know when the data are going to catch up for us to find it useful. Obviously, we care an enormous about mortality, deaths. We also care about long-term disability, and if somebody recovers but they're horribly debilitated from it, that's also critically important to understand. So I think to just sort of look at any one statistic by itself could be misleading. I think we actually need all three of those, but it's a really good point that any one by itself could mislead you about when it would be safe to sort of start things up again.
The other factor that we really don't understand is what the denominator is. I'm at Cohen Children's in New York, so we're in Queens, in the heart of everything. We've just started antibody testing for all our staff and for the general population here, and we're finding huge numbers of asymptomatic people who are COVID antibody positive. So, the percentage of patients who get sick may or may not be less than we think. It's likely to be less given just very anecdotal data of how many people are antibody positive but have been asymptomatic. So all I have to do is agree that we have a tremendous lack of information.
I completely agree with you. And I think it's important. There's a lot of, I think, misconception among the public and probably parents and kids and a lot of authorities about the utility of these antibody tests, right? Because they're getting better, but they still are not perfect in making sure that they're actually detecting COVID-19. Some of them are still detecting older non-COVID-19 coronaviruses that have been circulating for years. And then even if it is a COVID-19 antibody, we don't know that it's protective. And that's really important because we don't want people being like, oh, I have this test, it's positive. That's my passport to resuming life without a mask and throwing caution to the wind. And I think that could really be playing with fire.
One thing actually, let me ask you about is, because I've heard the winds that there is antigen testing that will become available in the relatively near future. And that could be something that would be very helpful for opening. And what have you heard about that?
Yeah, the FDA did just grant approval for the first antigen testing. I have not honestly seen enough about its performance characteristics to know. I know some of my laboratory colleagues are concerned that it's not ready for prime time yet, but I agree we need better ways to detect people who are, as you said, asymptomatically shedding, which could be as many as 25 to 50% of infected people. And that's a whole different ballgame, right? Because if people are feeling fine and going around and transmitting disease, that's a much more difficult thing to find a way to intervene to stop, right? You sort of need to sort of stop everything if that's the case. So that's really important information that needs to be sorted out to really know how to figure this out. I guess just the one other thing I would say is, what we're sort of also, seeing here is, because there's so much unknown here, there's obviously an incredible amount of fear and anxiety, and I think we all share it. I know I do. And it's what's fascinating and horrifying is various groups and various individuals are filling those unknown voids with conspiracy theories and fantasies that are being made up to fill these unknown questions and their answers. And I think we just need to really be careful and find common, reliable sources of information to share to really counteract that. Because it's even if there is at some point an effective vaccine, how are people going to know what to believe and who to trust that's going to let us find a way out of this? So I think our number one enemy here, honestly, is misinformation. And we have to, I know COCA is working on this, and I think that's fantastic, is providing reliable, up-to-date resources so parents, so staff, so camp organizations can have reliable sources of information when there's so much chaos swirling that makes it impossible to make plans because you don't know what's true, what isn't, and when more information is going to be available.
Dr. Raffi, are there specific sources that you would recommend people use or follow?
Yeah, it's so hard. Ordinarily, I would have said the CDC website would have been my absolute go-to, but it's fairly clear that that they're being very regulated in what they're allowed to say and what they're not allowed to say. I would say rely on your local state Department of Public Health. In these times, I find myself remarkably relying on my local California State Department of Public Health for leadership and reliable information about what's happening locally. I hope all of your local state and city and jurisdiction departments of public health will have the most up-to-date information on what's going on in your region that will help you make your best decisions. I rely on local health departments tremendously, and honestly, that's my best recommendation for right now.
Okay. Thank you.
Are there different strains of COVID like HIV? I mean, is it something that could mutate if you were antigen positive and you didn't have symptoms, but then could you be exposed to a different strain that would affect you differently?
Yeah, it's a great question, and we certainly don't know the answer to that. I thought you were going to ask something else. I thought you were going to ask, are there different strains which are more aggressive versus not aggressive? And it seems like the answer to that is yes. There are at least 2 different strains that have been circulating, and they're starting to do some of the genetic testing on the virus to understand what's different about some so they can design vaccines at the particularly more aggressive strains of it. It doesn't seem like it mutates or evolves as rapidly as even influenza does. And if you look at those curves that are sort of circulating on the internet of in 1918, the flu pandemic came and there was the first wave and then there was the second wave and it was even bigger and more serious. Some of that was antigenic shift because flu does that super quickly. It doesn't seem, and again, we don't really know, and anyone who tells you they definitely know anything about COVID-19 is lying, but it doesn't seem like it evolves as quickly as influenza does. Whether or not one strain would confer immunity to the other, we have no idea yet.
I'd say the only, what I might call encouraging fact is that I haven't heard about people having second confirmed infections, but it's still extremely early.
Yeah, I agree with you. I think people are watching those data very carefully. There are these odd reports out of China and South Korea where people were positive on a nasal swab, they had symptoms, they recovered, their swabs turned negative, and then they turned positive again. And what's unclear is if that's reinfection, if that's relapse, or if that's just when they got the negative tests, it was a sampling error or a test issue. So we don't know. That's one of the biggest unanswered questions that we're sort of waiting to see is if you've had it once and you've recovered, are you immune? Can you relapse? What does it mean? And you can believe that people are working round the clock and desperately to try and understand that as quickly as possible.
This is Yoram from Baltimore. I'm just curious from the nurses, the docs, others in the group, what you're seeing in terms of your patient populations. There was an unofficial COG study that, or report that came out among institutions that out of some 40 some centers, only about 80 kids, 82 kids with malignancies had contracted COVID and did really well. I know that wearing my hematology hat, because I do both heme and onc, it's more of our sickle cell kids we're seeing. So I'm just curious if you guys are seeing what that COG report had stated, that it's relatively few onc patients who are being infected.
Yoram, I don't want to say how many are infected, but I would say how many are symptomatic. We've had at least 5 or 6 patients who have tested positive. None of the in the oncology population, none of them have been particularly sick. In the sickle cell population, yes, and in our transplant population, yes. We had one patient with MDS, status post-transplant, who was intubated for a prolonged period of time, but she survived and she's now out of the ICU. But in the oncology patients, we haven't really seen them be symptomatic.
Yeah, thanks for the correction. You captured what I meant to say.
So I see there's some discussion in the chat about like testing before chemo and some of that, which is a great conversation, but I want to make sure we get a chance to talk about if there's camp specific questions that people have that we want to talk about, and then we can circle back to what's the conversation in the chat room. I wanted to throw out a question if I could, Dr. Raffi. What kind of things do you think we're going to need to be considering this time next year to help us know about changes we need to make at our camps, or what kind of things would you be considering for your camp next year?
Yeah, so looking into my crystal ball, which is a little bit cloudy right now, I'm hopeful by this time next year we'll have a highly effective, safe vaccine. And then I think we're going to be treating it a lot like a lot of the other vaccine preventable diseases that, we require our staff and our campers with, of course, the caveat of it would have to be safe in immune compromised populations and not a live virus vaccine, particularly for immune compromised kids, but creating herd immunity around that before we would want kids to come to camp. And I do think this is on top of that, ushering in a whole new era in terms of requirements for cleanliness and disinfection and screening before people come onto camp properties and to camp activities. How severe that ends up being is going to depend on, what sort of vaccine coverage and efficacy we end up having and whether or not it's safe and immunogenic in immune compromised kids. I suspect by this time next year, if we're so lucky as to have an effective and safe vaccine, we're not going to know a lot about how immunogenic it is in compromised kids. We're going to be trying to protect by immunizing all staff that don't have a contraindication. And we're going to be doing these really careful disinfection processes. Also, what role masks are going to have in that. It's hard to imagine camp programming with everyone wearing masks, and you almost don't want to think about it, but it may be our new reality, at least for a little while. I think it's too early to know, but I think there's nothing that's off the table, particularly, if we're going to try and have an in-person camp and we get general agreement that we think we can get herd immunity enough to do that in a safe way. I think there's going to be nothing that's going to be too safe for our kids with immune compromise. And so we may end up going overboard with the pendulum swinging towards too much at first, and then we'll get comfortable as we learn more. But I think the re-entry process, whenever that is probably going to be look very different than the camps that we're used to having or have had in the past. That's my suspicion. But again, so much unknown that it's almost irresponsible of me to even speculate.
Fair. Okay.
I have a question. So I'm with Camp Happy Days in South Carolina. We've canceled our in-person week of camp that we normally have, and we're doing virtual camp in a box. But we still have people that have been involved with the camp for like 20 some years that feel like we need to do something more for the kids and something in person. So they're pushing the idea of in-person programming for August, but it looks like we're still even peaking. Like they're reopening everything, but we haven't even had a steady decline in positive tests. But they're still reopening everything. And if that second wave is going to hit, it's probably going to be in August. And I'm trying to figure out how to communicate that it's probably best not to do any in-person stuff for any part of our population. And they've asked me to do like some sort of risk assessment for like kids that are way off treatment. But then I'm like, well, it's not really fair to exclude some kids. And even if they're off treatment, there's still some level of immune compromised if they've ever been treated and all this different stuff. How would you approach that conversation? Because I really don't think it's wise to try to do anything in person this year, but I don't know how to back that up with information or what to say or where to point them so that they can read it for themselves, if that makes sense. Because you're telling me it might even be hard to do, what I'm hearing is it might even be hard to do in-person stuff next year, much less in like 3 months, you know?
Yeah.
I've been a pediatric oncology nurse for 13 years and BMT too. So it makes me very apprehensive because I go down the rabbit trail of we're going to have to screen everybody. And if we do screen everybody, what does that screening mean? Like my executive director even wants us to like do pulse ox checks on people. I'm like, I can't do a pulse ox check on people if I'm not going to do anything about it. Like it's like number one rule. Like I can't check something that I'm not going to correct. Like I can't do that with my nursing license. And I don't know, because most of the board is non-medical. There are a couple people that are medical, but most of them are non-medical. And I'm, as the med shed, seen as the fun police, which is fine because it's my job to keep them the safest. But I'm just struggling with gathering the right evidence when the evidence keeps changing and there is really everybody will say what they want to hear, right? Like you can find something to support any opinion. So.
Yeah, and I think there's significant collective, brain power on this call that perhaps you guys know better than I do about how best to approach a camp board. But you're right, you can get any model to say anything you want. But if you look at the Mass General model that was just published last week online, I can forward you the link if that's helpful. What's really nice about it is it's state by state specific, and then you can change the parameters about what level of social distancing restrictions are being lifted and see what happens to your local epidemic. And I think maybe taking some of the graphs that model produces and showing different interventions or lack of interventions and what is predicted to happen is as much as you can do in terms of demonstrating the concern about, forget anything else about immune compromise versus not, although obviously the ante gets higher with immune compromised individuals, but when you put groups of people together in this context, and I think that's the argument, forget who it is, putting large groups of people together in this context doesn't make sense.
I keep telling them too, I'm like, it's not just our kids, our volunteers, everybody, because like there's no way for me to effectively screen everyone that comes into contact. Like there's just no way. And I'm like, and my nurse brain just goes down like, and I'm like, I don't even know how to explain where I'm going with this because it just is overwhelming. And I'm just like, no. So thank you.
You're right. You can't effectively screen everyone and you can't know that it protects everybody, even if they screen negative.
Kara, potentially you could couch it in terms of risk and what would it look like in the local newspaper if you have an in-person gathering and then there's an outbreak afterwards. What is your board going to do with that?
Yeah, that's what I told them too. I'm like, it's really more about, I want to not do anything right now so that we can keep doing things in the future, because I want you to look at what the headline will be. It won't be, wow, they were the only place to have camp. It'll be, why did they do that? And like, I've tried those avenues. Unfortunately, I have other people that have louder voices than me because that support me. So like if I don't get through, I'm able to be like, okay, can you tell them this? And it just gets heard differently, you know? But yeah, so it's hard. So.
I don't know. I don't remember who said it, but it was on one of these calls. And that's kind of what we've used with our volunteers who want to open things back up, was that, you know, we're going to be sad that we don't have camp, but I don't want to be sad that we did. And I don't remember
actually
whose quote it was.
That was me.
Well, we've been using it and we've held on to that. So good job.
Yeah, I'm like, and I keep telling them that. I'm like, guys, I'd rather be sad that we didn't have it than sad that we did. And yeah, that was me. So
Clearly it resonated. Other questions that people have? Is anyone else getting pushback or getting the, hey, things look like they might be better, we should talk about camp or doing something in person?
I didn't get any pushback from my board or anything on our oncology camp, but I'm getting a ton of pushback on our traditional camp. So that's what I'm currently working on. And I really appreciate this call just for some more good talking points as I work through that. Everyone was totally on board with not hosting our oncology camp, but we also run 8 weeks of traditional summer camp for our local area, and everyone thinks that it's a good idea to go ahead with that. And we're in Washington State, and we're getting ready to open up, but there's a lot of mixed feelings about that.
Yeah, I bet. Anyone else dealing with something like that? For those of you that either can't see it or there's been some great links posted in the chat, so please be sure that you look at that, and that will be part of the recording and notes from the after this session. Some articles, and also Dr. Rafi posted the link to the model he was talking about, so thank you very much for that. Other questions people or issues people wanted to bring up? So I'm maybe on a different note, and just something I'm curious from some other town halls I've been on. Are any of you as medical staff participating in virtual camps or the way camps are being run this summer? And if so, what kind of things are you getting to do?
Yeah,
I'm working on trying
more
to.
about well, we talked about it at our medical advisory committee meeting, how people could be involved, but we're still in the planning stage, and I'd love to hear other ideas.
If I'm remembering right, someone was telling us about the Medical Monday. Is that camp on tonight? I wanted to hear how that was going. Or other ideas that people are using or got a chance to be a part of?
We finally got the official decision from our medical director that we wouldn't be having camp at all this summer, which is really sad, of course, but I'm also very happy that it came through so that we can start planning virtually full throttle. Leading up to it, I've been doing a lot of research, and there is a lot of good resources out there that are showing you how to do like a traditional game and how you can translate it to a virtual setting. So that's pretty exciting. We're also we have an impact council, which is focusing mainly on teens. And we really need to dive into that council because teens can be a little bit difficult just to get involved in camp in general, but now getting them to log on to WebEx or a virtual setting. So talking, I know I'm a little bit on the younger side, but still I'm not a teen, just talking to the younger ones and seeing, you know, what would interest them and what's a title that would entice them to actually come and sit down rather than just like calling it a teen hangout. So another big focus I feel like is a huge marketing and marketing correctly. So those are some things that we're looking at, but we actually get to go full force with it. So nothing super helpful, but I was excited that we actually get to do that now.
It's nice to have a decision made so you can move forward. Sometimes the waiting's worse than anything else.
We're asking for some video messaging so that we can use that in the weeks up to camp, and then also kind of at opening ceremonies and that kind of thing, and encouraging everybody to be at some of the group gatherings.
Anyone having trouble getting medical staff to participate because they might be working or have other responsibilities this year that they wouldn't normally if they were actually got to be at camp?
Rich here from Camp Kids to Kids. Our medical team actually wants to caravan with the Camp in a Box, since they really won't be able to do a lot of face-to-face time. They can, but they decided that they want to do that, bringing the supplies to the campers. So that's how they're trying to get involved more. So yay them, I don't have to drive.
Okay.
Yeah, that's, I took over the Camp in a Box section of it this year so I could stay involved, and then we're letting any medical staff that is able and wants to just let us know they want to participate, and then plugging them into different activities and just trying to make sure that everybody gets a chance to stay involved.
Okay, great.
This is Amy from Can't Make a Dream, and we are plugging in with some nurse practitioners from Sloan Kettering for our brain tumor camp and coming up with some education sessions and enticing our campers to go to them. If they go to enough, they get prizes or a t-shirt or something like that for getting our nurse staff and NPs and doctors involved that way.
Okay.
This is Dr. Mike from Okazi. One of the things that we're still hearing from some of our medical staff is that they don't know what their summer is going to look like, that things have been turned so upside down with scheduling. There's backlogs of almost everything that need to be caught up. And so some of them at this point are hesitant to commit because they're not sure where they're going to be when summer rolls around.
Okay.
This is Edith from Camp Sunshine. We're trying to have our medical staff run one of our evening programs like trivia night, or as many as can get on there do it. And they are also going to do a video for us. But yes, we are also, a lot of them cannot participate during the day. It'll just be like evening time after work.
Okay. Mary Ellen posted a question. Are people still requiring application for campers? And are you making any changes to your current application that might be more applicable to face-to-face camp experience? Anybody want to speak to that? Or are people at that point yet?
We are for Camp I Hope. And we, Camp Doc is our registration platform. And so we're working with them, and we really simplified the application for both the volunteers and the campers. And if they were already pre-registered, they're going to be able to opt in, and they'll pull the data over, so there's not a whole lot that they have to redo. What we're struggling with, and we've been looking at several different resources out there, is making sure that the waivers that we have cover the virtual and security. And so we've got the application piece done. We just need to finish up the waivers and get it out there.
Okay.
Hi, it's Michelle. We have completed our application process. We work with CampMinder, and we created a virtual camp application that supplements the regular camp application, because we want to be able to use the basic data about the children should we at any point in time during the year for any year-round program have some basic information to add on to as we would with our regular camp. So we have our permissions in line. We have a whole lot of permissions. If anybody wants me to share it with them, I'd be more than happy to share. And we are we're doing the registration process, and we're only requiring the preliminary information from our regular camper application packet and the permissions for virtual, and a photo, because we feel a photo is very important should we see the kids on any Zoom platforms. And it allows for new kids to register for this summer as well, and for the staff that are on the calls to be able to recognize them via the photo, so we're using the photo.
I'm going to start working on our registration or application for a virtual camp. And some things I wanted to include was the signed consent. So as the parents are signing up the kids, they're doing the signed consent all in one. So it's not like we have to chase them down and get those signed consents. I also was going to ask if there were any siblings in the home as well, so we could get patients and siblings done in all one. So if the sibling pops in, we know who it is and that it's okay that they're on there. Another thing that I'm thinking about including in the registration is if they want to receive the camp in a box, they'd be able to check yes or no. And then if they did, they could fill out the address that we can send it to, and then even the name to address it. So instead of sending it to Mary Smith, the mom, we actually can send it to Elizabeth Smith, the daughter. So it feels a little bit more exciting for the kids to get it. And then in the camp in a box, if there's any siblings, we can address the siblings in there as well. I also thought about maybe asking questions about what their device availability at home is.
We've done that.
If parents are working from home and they're stuck on one computer, they won't be able to join as freely on live. They'll be more inclined to join or see pre-recorded what we post. So it'll just give me a better understanding of on their side what to expect of who would be logging in, who won't be logging in, so we know what participation rate might look like and whatnot. So those are some questions I'm thinking of. I definitely like the photos though as well. That's a good idea.
We also have whoever is leading the session, we have somebody that's on, not necessarily the person who's running the session, but an additional staff person who's taking attendance. And so that for our population that have registered, we know who has been on a regular basis. And if we haven't seen anybody for a number of days, we'll pick up the telephone and call them and make sure that they're okay. And that's part of what we do normally in camp anyway. If we don't see anybody for a couple of days, we'll pick up a phone and call them, see what's happening in the family. In terms of Camp in the Box, because we wanted to save money on postage, we are actually doing a family box with individual packages within that family box for all of the members of that family, so that everybody will have their own package, and it saves a little bit on the cost of shipping.
We're gonna do a kind of a box pickup day, kind of like the schools have been doing for packet pickups for schools, and have a drive-through for families to come pick up the stuff. And we're gonna have different age group boxes, and then we're also gonna have like a family box with like random supplies that they may or may not have, like crayons or scissors or whatever, depending on what the activities are. Yeah, it's kind of everything else, plus we're kind of gonna do a drive-through pickup thing at each of the different spots that we normally get kids from.
I just wanted to touch on the taking attendance. We use WebEx at MD Anderson, and there is a report that you can pull and see who logged in. I don't know if that's something that you can do on the other platforms, but it might save some insanity of making sure somebody's there, and you can check it later of who actually was signed in, how long they were signed in, and whatnot. Just wanted to throw that out there.
We're also using a Bloom's platform, which is like a classroom platform. That allows for us to also send reminders to the parents of the sessions that we're running and which children, what age groups can use those, can log on, that's more appropriate for them. The other thing is we are asking in our application if we are allowed to contact, if the parents will allow us to text or email the child directly to let them know as a reminder of what sessions they may be able to attend that are appropriate for them, that they're scheduled for.
So I was just in a session earlier and I found out that we're not using any new volunteers, so we'll just use the base of what we had last year. And then training. So I wonder when we're doing training and what the role of medical will be, and if you have a relationship with these families and the campers, if they're going to look to all the medical folk for the current scoop on what the doctor just presented to us. So it'll be kind of interesting to see how much they rely on you all to provide them where we're at whenever camp starts. Got quiet.
One of the things you mentioned, training, it's not in response to your statement, but we're also going to be doing parent orientation and talking about online etiquette for the kids, as well as doing staff orientation online.
You know, Brian, in response to your question, I think, and it's just really in my head right this minute, but I'm thinking, you're right. We're doing the same thing. We're not taking on any new staff. You know, we have a very large staff to begin with, so taking on new staff is not necessary this year. But I'm thinking, you know, with our online training, virtual training that we'll do with the staff, it might be, you know, since they are all returning, to go over the same medical needs may not be necessary. However, taking it from a medical psychosocial standpoint, that might be more appropriate for some of our medical staff to do a training session on, looking at, you know, potentially what the virus has done to children in general, looking at the whole idea of the isolation aspect of it, and also even talking a bit about the grief aspect of not having camp or not having a physical camp. So maybe, you know, utilizing our medical staff in that respect for training. And then obviously any psychosocial staff that we have, child life or social workers, would be ideal at that point too. That just, you know.
Yeah, who knows where we're going to be in 30 or 60 or 90 days, depending on when you have your camp. And
correct.
It could be a whole host of new information that they're going to look to you because maybe you're the medical person they trust that they have a relationship with.
Right.
I think that's a really good point, Matt. And, you know, in some ways, our families are impacted by this shelter in place a little differently because a lot of them were given similar kinds of restrictions anyway because of the immunocompromised state of the patient and their family, so that they would stay away from crowds and they would wear masks and make sure that everybody was hand sanitizing and wiping down everything. But, you know, one of the consequences of that could be that they're more familiar, but another consequence could be that it's like PTSD, it's happening again, and so it could make it a more difficult situation to be in. So I think having the opportunity to discuss all those, the psychosocial and emotional overlay will be an important role that the medical staff can play.
Other ways people are going to incorporate their medical staff in training or in getting prepared for camp? These are some great ideas.
Are there any other questions or concerns that anybody has at this point as far as things that are going on with their camp or in general, any other questions or concerns that this group might be of service?
You know, I just thought of something real quick. Rich, one of your, let's see, who was it? Crystal, who's Child Life, sent me a coloring book that their university or college created, and it kind of went through some real basic, it probably was like written for K through 6 or maybe 5, about washing hands, about the virus. And it was just a good, something for them to work on and learn and color while they were learning about the virus. Did she, I'm assuming you have that, or I could try to find it. It seems like she sent it to me and I farmed it out a while ago, but Rich, it was, I think, Crystal that had it, if that was her name.
Kristlyn?
Yeah.
I will look.
Okay, I'll look too.
That's a cool idea. That's a cool idea.
One question I have about activities that doesn't need to be answered right now, just I guess something to think about and then talk about later. Are y'all focusing your activities mainly on just let's color, let's build something, let's go play, or are you trying to have some psychosocial goal behind it like we would at camp? I know some of the activities are more like, let's talk about this and how has this helped you, and it's a little bit more mental. We've been talking about it and it seems a little bit hard to do that over virtual to connect. So I'm just wondering if people are trying to find ways to do those kind, like the emotional ceremonies, and seeing if y'all are doing anything like that, or are you focusing more on let's just, you know, have fun and just go with it?
We've been talking a lot of our, even at camp, a lot of our deep conversations that occur typically are sitting around the arts and crafts table or sitting around in the kitchen, you know, where we have cooking classes. So I think for us, you know, we're going to schedule a few sessions specifically with our social workers and child life, just to make sure that kids are doing well psychosocially and emotionally. But I think the majority of our program will really be set up similar to camp, where kids can talk freely and with each other and with the staff, but during those, you know, those other fun things that they would when they were at camp anyway. So I don't think, other than maybe, you know, one or two specifically designed sessions from professionals, the rest of it will just really try to mimic camp and their experience as much as possible.
That's something we've been talking a lot about as well. A lot of the typical camp experiences are designed to allow people to express, you know, really deep emotions, and they get very emotional. And to recreate that in a virtual format would probably be difficult anyway, because people are less likely to feel comfortable just staring at faces on a screen as opposed to being in the same location and, you know, really feeling like they are more connected. And the other thing that worries people, and I'm one of them, is that, you know, if you are sitting in a room with a group and you're talking about heavy things, you can see all of the people who are there. You can see who's starting to look distressed. You can, you know, go over and sit beside them and put a hand on their shoulder. You can follow up with them later in the day. Maybe some people might even need to take a break out on the porch for a couple of minutes and then come back. And you can't do any of that when you're doing it virtually. The other side of that coin, though, is that one of the things that is most valuable to the kids is the opportunity to talk about some of those difficult things with people who understand, because they've been through similar circumstances. And so there are those who make the argument that to take that opportunity away is really taking an important part of the camp experience. And so we're trying to look for how to define the appropriate balance of making sure that we feel comfortable that we're keeping track of how people are doing in that context, but trying to allow the opportunity for those conversations to occur. And one of the things that I think will make that easier is smaller groups. So, you know, you could divide up into breakout rooms in Zoom or whatever the similar technology is for other platforms, and have groups that have a couple of staff and a smaller number of campers. And then it's easier to touch base frequently and keep track of whether anybody is stressed, and you know exactly who's there, and can also circle back later and check in. If you've got, you know, 25 people in a virtual room, you know, some might never say anything, and so their face is not prominently displayed, but they might be really sad and reacting very strongly to some of the things that are being said. So it's a problem to which I don't have a good solution, but definitely one that that I think we are thinking a lot about, and I'm sure many of you are as well. If anybody has any brilliant ideas, I would be delighted to hear them.
One of the things that we considered, thought a lot about is kids coming to camp, there's a level playing field. Everybody's equal. You don't see their background. You don't know, you don't see them in their environment. And we're actually going to be going into people's homes via Zoom. And so we're going to be seeing kids in a very different light. We may see things in the background happening with the family. And we need to prepare the staff for that as well. So the level playing field that camp provides, where everybody is equal and there's that base for everyone, that's not going to necessarily be existing on a virtual platform. So we need to be aware of that.
That's a good point, Michelle.
And I think that the other corollary is that the lack of privacy when you are at camp in a cabin with your group doing cabin chat, talking about deep concepts and philosophical approaches to how you live life. That's a whole different thing than maybe being on the other side of a hollow core door that people can hear you through anyway, or maybe just sitting in the corner of the room where there are 5 other people. They're not going to have the same sense of being safe in terms of privacy about what they say and what they don't.
Thank you everyone for sharing. I don't want to cut off this great conversation, and hopefully people will keep it going, but to be respectful of time, we are getting close to the end of our hour. We do have a poll we'd like to have you fill out, so I think Dawn is going to launch that here, and please give us your thoughts as to how this session went. And thank you again to everyone for participating, and especially thanks to Dr. Rafey for taking the time to join us tonight. Really great to have you here and share all that wonderful information. Don't forget that there will be a recording of this along with the notes and the questions from the chat room so that you can see all the links and things that have been shared.
Yeah.
And thank you guys very much for organizing and hosting these. It's really great to have the opportunity to come together and talk with like-minded folks about all the problems that we're wrestling with. So thanks a lot.
Thank you. And just so folks are aware and they can mark their calendar, we do have another medical town hall scheduled 2 weeks from today, which will be May 27th. And we do have another guest speaker that will be with us that evening. Tracy Gaslin will be with us from the American Camp Nurses Association. I think I said that right. The ACN. So she will be, she'll join us on the 27th. So please be on the lookout for that date.
I did find that coloring book and I sent it to Jennifer, so she's going to have it posted somewhere along with this video, and if you're interested in it. It was from Johns Hopkins Child Life Center.
Thank you. And just so in case folks want to capture the group chat before you sign off, there are 3 dots on the bottom of the group chat. If you click on those 3 dots, it will actually save the chat directly to your computer. This way, in case you don't want to wait for us to post it, you can always just click on the 3 dots and save the chat to your own computer. And this way you can have those links so that you can access those links as soon as we sign off, because I know you guys are excited about it.
Thank you everyone for joining us tonight.
Thank you for doing this.
Thank you all so much. Be well, be safe.
You too.